Welcome back to Long COVID Doctor, an educational series for those of you who are still suffering from long COVID. I'm Dr. Tim Robinson, formerly a GP, family doctor for 30 years, and now working in Long COVID Services for 5 years. I post on all the usual podcast channels as well as here on YouTube. I hope you find my postings helpful. If you do, I would like you to click subscribe. We need to spread the word. We need to get this information, these resources out to you, especially as certainly here in the UK, a lot of the long COVID services are being withdrawn and shut down. So thanks for any feedback and apologies in advance, but I just haven't got time to answer all your queries and respond to the comments. However, they're really helpful to me in order for my future postings. So keep them coming in, please. My usual disclaimer: any advice or treatment I mention in these podcasts and today's update should only be considered after discussion with your own GP doctor. Right, so let's get into it. This is a talk all about POTS in long COVID. POTS. I've divided it up into two parts because I don't want to overwhelm you and give you too much information, especially those of you who may have fatigue or brain fog, cognitive impairment. So I've sort of divided it into two parts. The first part is basically the causes, the explanations, what patients are telling us in our long COVID clinics. And the second part is really the treatments and the best management of POTS. So here we go, POTS in long COVID. So first things first, what is POTS? Well, basically POTS is an abbreviation for, wait for it, postural orthostatic tachycardia syndrome. Okay, POTS, postural orthostatic tachycardia syndrome. Let's take it pick it apart. Postural, okay, it's to do with your posture, okay, your position. Orthostatic is a fancy Latin word for standing upright. Tachycardia, again, is probably derived from Latin, and that is to describe a rapid heartbeat. And then syndrome. A syndrome is a word that describes a collection of symptoms. So, postural orthostatic tachycardia syndrome. But what does that mean? Basically, let's think about what happens normally. So normally, your heartbeat is controlled by your autonomic nervous system, the automatic part of this nervous system that you don't actually have to think about. It happens automatically. And it controls specifically lots of things, but specifically for this presentation is the heartbeat and the blood pressure. Not only the beat, the strength, but also the frequency, how often, how fast or slow the heart is beating. And basically this is like I said, an automatic process which we don't actually have to think about, and the heart adjusts itself according to the need. And specifically, the heart, when you want to do exert yourself, needs to speed up. Interestingly enough, when you stand up from sitting or lying, then the heartbeat increases, but only briefly. The blood pressure is then sort of maintained at a normal level. If this autonomic nervous system is not functioning normally, it's dysfunctional or faulty or abnormal, then the heartbeat and the blood pressure is not controlled as it should be. So when you change position, it then doesn't respond to that change in position. And so consequently, the heart rate speeds up. Often the blood pressure drops down. So this is what is happening in postural orthostatic tachycardia syndrome, POTS. What are our patients telling us? Well, basically, they say that, okay, I have, doctor, I have an awareness of my heartbeat with prolonged standing when I'm upright. When I'm sitting, when I'm lying down, I'm not aware of my heartbeat. When I get up and I'm standing still, waiting in the queue in the supermarket, or, walking around the house sort of slowly, then I become aware of my heart beating in my chest, and it's a sort of a thumping or a thudding sensation. Sometimes patients say that they actually feel that thumping and that pulsation in their neck. They describe often a very rapid heartbeat. So it's sort of not going along at sort of 70, 75 beats a minute. It's going on along at sort of 100, maybe even 120 beats a minute. But interestingly enough, it is when they're standing up, okay? When they then settle down, because they probably want to rest and to try and relieve it because they don't feel well with their heart racing along at a rate that they're not used to, and they're feeling these palpitations. When they sit down, interestingly enough, their heartbeat settles. So that's what our patients are telling us. They're also telling us that they have some associated symptoms, often lightheadedness or a faint feeling, or nearly fainting, or sometimes even fainting, blacking out, like sort of everything, the curtains coming down and sort of your vision going all black out and seeing stars, that sort of thing. There may be associated sort of clamminess or sweatiness that happens with this rapid heartbeat. And understandably, it's a scary situation. You're not used to it. You're young. Most of our patients are in that sort of 30 to 60 category. You're still young and you're not used to this. And so naturally that makes you feel a bit anxious and fearful. So that's what our patients are telling us. These associated symptoms along with their pulsation, feeling in the chest or in the neck. So what should a patient who's experiencing these palpitations and those associated symptoms do about it? Well, obviously, any new symptom, you need to report that to your doctor. Okay, we mustn't be COVID blind. What do we mean by COVID blind? Well, or because you've got this new symptom and you have long COVID, you can't necessarily link them together. It might be the case, but you can't necessarily. Other causes need to be excluded at the same time. So your palpitations, etc., might have happened just out of coincidence. You've got long COVID as well. So I think you've got to be safety first. Make sure that you take the new symptom to the doctor. We need a diagnosis. So we must not be COVID blind. So you go along to the doctor, jolly good. And what do? Well, you tell the doctor what you're experiencing. The doctor will then take what's known as the history, the story, the account. And then also take in a sort of general history, other sort of elements to the general medical history. Then after that, it's obviously on to examination. And first things first, you want to measure the pulse rate, then listen to the heart rate, checking that they're the same. Blood pressure, preferably standing, especially as what you've said to your doctor is that when I'm standing in the queue in the supermarket, I've been standing for 10, 15 minutes, my pulse races. So you want to have your blood pressure measured when you're in the upright standing position as well as in the seated position. And then on to investigations maybe. The GP may request, say, blood tests looking for other causes, recognised causes of palpitations, say anemia. Iron deficiency anemia leads to palpitations. So being anemic causes this to happen. Excessive thyroid activity, so thyrotoxicosis or hyperthyroidism can lead to tachycardia, palpitations. Kidney function, problems with kidney function can lead to palpitations if what's known as the electrolytes, the salts in the blood, are abnormal because of there's a kidney problem. So, blood tests. Then ECG, as it's a heart pulse situation, obviously, not surprisingly, the doctor will probably want to do an ECG, electrocardiogram, electrical tracing of the heart, to look at the rhythm, check that the rhythm looks normal, and the heart tracing shows the normal cardiac complex, the QRS wave, on a regular basis, and measure between each of those, say, each of the Q waves or the P waves, just to make sure that the interval between the each successive P wave, say, is the same to me. So hence checking the rate. ECG will also reveal, say, heart strain or situations where the heart is really struggling a little bit to beat normally. The GP might, if these palpitations are happening on a prolonged basis, the GP may request what's known as a Holter tape, or a 24-hour trace of your heart rate, or 3 days or 7 days. You can get these 7-day heart traces now that are then analysed. GP may want to do chest x-ray, again, thinking heart things, thinking maybe some heart failure, checking for heart enlargement. So those are all the history, examination and investigations that the GP will go through, the normal process. And having been through all that process, the GP will then be able to make that diagnosis. All along, the GP has also been checking for what's known as red flags. Any of those worrying symptoms or signs that make us suspicious of another underlying more serious condition. So chest pain, for example. If the patient is complaining of chest pain as well as the palpitations, then you're concerned. The alarm bells go when we hear about chest pain. We think, oh my goodness, is that chest? Is that heart strain? Is that angina pain, heart muscle pain? Or is that, imminent heart attack? So chest pain is a red flag. Unexplained fainting, drop attacks. A GP will certainly want to do an ECG looking for complete heart block, for example. Unexplained shortness of breath, along with other cardiovascular symptoms, obviously needs to be investigated. And more often than not, that usually will result in a referral to a specialist in the hospital. So a cardiologist, if it's has a cardiac feel about it. So those are red flags. Presuming there aren't any red flags and you've got palpitations and you've ruled out all those other causes for palpitations, then that does leave us with palpitations as a result of your long COVID. Basically, there are roughly speaking, four common categories of explanations for palpitations. So those palpitations may be just a one-off irregular single beat. This is quite innocent. These are called extrasystoles, and we'll have them. Majority of us don't realise that we have an extra beat here and there, just slotted in, and then normal rhythm thereafter. So extrasystoles are quite common. So no real treatment for that. So it is an explanation when suddenly you feel, when a patient says, during my general practice years, a patient would say, every now and then I get this extra thud. I don't know what it is. And I'll then go through the motions and do a ECG, and lo and behold, every so often I see an extra pulsation. We don't treat it unless it's very frequent. Then there's this other condition called atrial fibrillation. Again, like I said, when you're looking at the ECG, electrical tracing of the heart, you're measuring between each of the cardiac complexes, and so hopefully, start again. Atrial fibrillation, the distance between each of these complexes is irregular, and so this is something that obviously needs treatment, because uncontrolled atrial fibrillation can lead to a blood clot forming in the upper chambers of the heart, and then that can lead to a stroke. So we need to identify that and get it treated. And then there's two, if you like, really much more exclusively long COVID explanation or diagnoses for palpitations. First is inappropriate sinus tachycardia, and the other is, wait for it, POTS, postural orthostatic tachycardia syndrome, the subject of this talk. So let's just focus on inappropriate sinus tachycardia. So sinus tachycardia is rapid heart rate, rapid regular heart rate, prolonged runs of that, and it may be minutes, and maybe an hour. Again, came across this not infrequently in general practice. So these are runs of regular beats, and you probably, because this is quite uncomfortable, a bit worrying, you're probably going to need treatment for this. And then finally, on to POTS. So this is regular runs of extra fast heartbeat also, but with this positional aspect to it. When you get up, stand up, and it's prolonged standing, leads to this excessive heartbeat. So remember, what POTS stands for? Positional orthostatic. So position, orthostatic, standing up, tachycardia, rapid heart rate, syndrome, collection of symptoms. So that's POTS. What's the explanation behind POTS? Why does it happen? It's a strange thing, isn't it? Rapid heart when you change position. I mean, you're prolonged standing. So basically, it is like I said, it's going from lying or sitting to standing. So what happens in this process that we undergo so often throughout the day? So basically, whilst we're sitting, blood is because of gravity is drawn down and sitting, lots of blood in the legs, thighs, lower legs, thighs, and pelvis, lower abdomen. When you get up, stand up, all that blood that's down there in the lower extremities needs to be pushed up into the core, into the center of the body, basically up to the heart, and then on up to the head. Okay, so in POTS, this process of pushing the blood back up against gravity, back up into the core of the body, heart and head, is in some way impaired. Okay, so therefore less blood is returned to the heart, and this leads to an inadequate filling of the heart, and this leads to a drop of the blood pressure. To compensate for that and to get more blood way up into the most important part, and that is the brain, the heart rate speeds up. So the rate is accelerated in order to get more blood upstairs into the brain. And with this increased heart rate, that is felt as palpitations in the chest. You feel the thumping in the chest. So that is POTS, postural orthostatic tachycardia syndrome. Okay? Now, how do we diagnose it? So, basically, POTS is diagnosed if your heart rate increases by 30 beats per minute or more, or it sort of runs along at 120 beats per minute at 10 minutes of standing, having been horizontal, lying flat. Okay, so I'll say that again. So if your blood pressure, beg your pardon, your heart rate is measured when you're lying flat, and then you stand up, and if your heart rate goes up more than 30 beats a minute, or it's sitting along at 120 beats a minute, then you have POTS, and that is in the absence of a drop of blood pressure. So this is exclusively the increase in heart rate when you're going to standing up. I'll explain why I'm saying that in a minute. So if your pulse or heart rate does increase by 30 beats a minute, you have POTS. And that is after 10 minutes. So when that is measured 10 minutes later, you have POTS. In medicine, there's no hard and fast rule for everything, is there? So yes, certainly in the clinics that I work in, help out in, there are some patients whose heart rate goes up, so 20 beats, 27 beats, 26, 27 beats a minute, and they feel terrible, and they have all the symptoms of, POTS, and they can feel the heart rate. If they have all the symptoms and they're at 27 beats a minute increase, I will usually diagnose that patient as having POTS because they're symptomatic and we've got a demonstrated increase, regardless of the fact that it didn't get up to the magic 30. The magic 30 is quite an arbitrary level that has been picked based on statistical standard deviations in a group of patients who were tested, and that led to this creation of this diagnostic tool. So long story short, if your heart rate goes up by 30 when you're sitting or lying, up by more than 30 or above, basically you've got POTS. So how do we actually formally test it? Okay, well, the gold standard is something called a tilt table test, where you lie on a table with your head lying flat, and then it is tilted so that your head is 60 degrees above the flat, above 0 to 60. Not 90 would be full upright. So 60 degrees up from the horizontal. And in that position, the blood pressure is measured on a regular basis over those next 10 minutes. The only problem is tilt table testing is quite difficult to access. If you can access it, the waiting list is long. The easier test and safe test is something called the active stand test, active stand test, or the NASA lean test. So the NASA, as in NASA, the space agency, this is that NASA test, NASA lean test, that the astronauts are subjected to prior to going off and doing what they do in outer space. So the NASA lean test or the active stand test. And as I've described, basically, the patient is laid down flat on the bed, on the couch, or a sofa, whatever. And the pulse and blood pressure are measured in that lying position once they've been lying there for 3 minutes. Then the patient is asked to stand up and stand sort of upright, leaning against the wall, with your feet 30 centimeters apart, so you're nice and stable. And so in other words, assisted. You don't want to be doing this on your own because, you might drop your blood pressure, fall over, faint, and hit your head on the table as you fall to the ground. So you need to have someone, a friend, family member, to be with you when this is done and to do the readings. Yeah, so, that's one less thing for you to be thinking about, worrying about. And the blood pressure and pulse are measured at 2 minutes standing, 5 minutes standing, 10 minutes standing. That's the active lean test or the NASA lean test. Right, that's how you diagnose it. Okay, let's think a little bit more about back to the topic. What causes POTS? As you're quite familiar now with my podcasts and YouTube videos, basically, I keep going on about this, don't I? It's really important that you understand the causes. So, what causes POTS? Well, go back to basics. Let's think about the COVID infection. What has the COVID infection done? It has brought about inflammation. It's brought about inflammation of those blood vessels, both big ones as well as those small ones, down the peripheries in your hands, all the way down your arms, all the way down your legs. It's affected, inflamed those blood vessels. It's led to the other inflammatory processes. So inflammation, the mast cell activation. Again, look at the podcast, listen to the podcast, watch the video on mast cell activation, MCAS. Another consequence of inflammation in COVID, hence long COVID, is the microthrombi, those little blood clots that are here, there, and everywhere. They can go and block those blood vessels in the peripheries, for example, as well as up in the brain, in the brainstem. And typically in the area in the brainstem that is controlling the heart rate, the autonomic nervous system functions. And then there's autoantibodies. So autoantibodies, which I talk about in other postings. So where the immune system is malfunctioning and attacking tissues, nerves, muscles, that can all contribute. So all that inflammatory processes underlying COVID that leads to long COVID cause all those problems. And like I said, it's throughout the body, but also can happen in the brain, in the brainstem. It can happen in those nerve sensors, those receptors that detect pressure. And where are they? They're in the arch of the aorta and in the upper chambers of the heart. The carotid body that controls the heart rate also. So any of those can be damaged in this whole long COVID process. And then there's the damage of the autonomic nervous system. Again, this is more sort of the autonomic nervous system is throughout the body, but in the part of the brain where there's the balance of the autonomic nervous system, the balance of the sympathetic with the parasympathetic nervous system. So the sympathetic nervous system is, if you like, working excessively, and if you like, the parasympathetic is underactive. So those are all the sort of causes that all the research into long COVID has revealed. And as we know, you may have any number of those causes happening at the same time. I've talked a lot about the nervous system control of the pulse and blood pressure. And obviously that's all part of what we know as when the autonomic nervous system is not working well, we call that the dysfunctional autonomic nervous system, or shortened to make this word dysautonomia. And someone with dysautonomia may have, over and above the POTS or inappropriate sinus tachycardia, and they may have a drop in the blood pressure. I said the diagnosis of POTS is really just this increase in pulse rate in the absence of drop in blood pressure. But you actually can have POTS as well as something called orthostatic hypotension. So your pulse may be going up, and also you may have this drop in blood pressure. Other autonomic functions go haywire in dysautonomia. So temperature regulation is a problem. People feel shivery when it's a hot day, for example, can't get enough layers on, etc. Again, such a common feature of long COVID. Nausea, ringing in the ears, balance problems, gut problems, breathlessness, pain, hypersensitivity, sound, smell, touch sensitivity, taste hypersensitivity, sort of can't stand the light, can't stand excessive noises. These are all dysautonomic symptoms which could be there with your POTS. So I've talked a lot about the causes. Like I said, so important. We need to know what we're dealing with, the diagnosis. We need to know how to best treat them and to understand those causes. And that gives us peace of mind. It gives us that sort of that validation that, actually, if we're being accused of being lazy or our symptoms are not being believed, then these are the causes that research has discovered and validated. So there we are. That's really the end of the first part of this talk on updated talk on POTS, and what our experience is, certainly in the patients who we're looking after in the long COVID clinics. In part 2, I'll talk about how we're going to go about tackling those symptoms, how we're going to try and help treat, and the strategies we use to treat POTS. So, see you there.